assessing PrEP adherence, sexual practices, and HIV and STI incidence among men of sex with men and transgender women in 2 municipal STI clinics, which were in San Francisco and Miami, and a community health center in Washington, D.C. Each of these clinics serving large numbers of MSM with high HIV incidence of greater than 2% across the clinics. And enrollment in our study began in October 2012, which was shortly after the FDA approval of PrEP. And Dr. Stephanie Cohen previously reported high levels of interest and uptake of PrEP in our study. Participants were provided 1 year of daily oral Truvada along with regular HIV testing, counseling, and clinical monitoring. And PrEP adherence was measured using tenofovir diphosphate levels, which is the metabolized form of tenofovir. It's measured in dried blood spots, and it provides an estimate of the frequency of dosing. Participants with drug levels consistent with taking 4 or more doses per week, which was associated with high levels of protection in the IPREC study, were considered to have protective levels in our study. In terms of our results, we enrolled 557 participants with a mean age of 35, 48% were white, a third were Latino, and overall we saw high levels of PrEP adherence in our study. Among 294 participants who were selected for dried blood spot testing, nearly all had detectable drug, and 80 to 86% achieved protective drug levels at follow-up visits. We did find that those who reported higher risk behaviors and those who were stably housed were more likely to have protective levels, while African American participants and those at the Miami site were less likely to have protective levels. Over 1/4 were diagnosed with an STI at baseline, and STI rates remained high but did not increase during the study. Also, 2/3 reported condomless receptive anal sex at baseline, which also remained stable during follow-up. However, despite these high rates of STIs and reported risk, we only saw 2 individuals who became infected with HIV during follow-up. And both of these occurred in the setting of low or undetectable drug levels at the time of seroconversion, suggesting that PrEP was not being taken consistently. HIV incidence in our study was very low at 0.43 per 100 person years. So in conclusion, the majority of MSM in our demo project were able to achieve high levels of PrEP adherence. Despite high rates of STIs, few participants became infected with HIV, and these infections occurred in the setting of low or no PrEP use. PrEP adherence was higher among those who reported higher risk behaviors, which will likely increase the cost effectiveness and impact of PrEP. And our results support strongly the scale-up of PrEP in these similar clinical settings. And we do recommend quarterly STI screening for MSM taking PrEP in these settings. And finally, our findings highlight the need for strategies to address racial and geographic disparities, as well as housing instability to maximize the impact of PrEP. Thank you.
Thanks, Al. That's just really exciting and important work. Our second speaker is Dr. Beatirz Grinsztejn. She's the director of the STD Clinical Research Lab at Fiocruz in Rio de Janeiro in Brazil, and she's a faculty member of the graduate program in infectious diseases at Fiocruz. Beatriz is the principal investigator of the NIH ACTG and HPTN clinical trial units in Brazil, and she was co-PI of the IPREC study of PrEP in Brazil, and she also served as the prevention track co-chair for this conference. So, Beatriz, please.
Thank you, Chris. So it's indeed my great pleasure to present you today the first results from the PrEP Brazil demonstration study. PrEP Brazil demonstration project is the first PrEP demonstration study in the middle-income country for MSM and transgender women. So Brazil has a concentrated epidemic where MSM and transgender women are highly affected. Where overall HIV prevalence is around 0.6, and among MSM it's up to 14.2 in the country. And although we have several prevention and treatment tools made available by the Ministry of Health at no cost, such as universal access to antiretroviral therapy, the epidemic goes unabated among MSM. So, building on our experience with PrEP trials, we have designed PrEP Brazil demonstration project, and from April 2014 to April 2015, we have approached almost 1,000 men while they were coming for HIV testing or for PrEP services or men who were self-referred to the project. This project is ongoing in 3 sites in Brazil, 1 site in Rio and 2 sites in São Paulo, and these cities are the major epicenters of the HIV epidemic in Brazil. So from those 1,000 men approached, 798 were deemed eligible for the study, and we were targeting high-risk MSM and transgender women. And from those 798, 409 effectively enrolled in the study, and this reports an uptake of 51%. And we consider it a high uptake in this population. Uptake was higher among those who perceived themselves under higher risk, who had also higher sexual risk behavior and higher risk perception, and predictors of uptake were having higher risk perception, risk behavior, prior PrEP awareness, and being trans. And the major points we take from this is that PrEP was highly well received in the community, although a lot more on community education is needed, and also that targeted efforts to enroll and to educate trans people paid off, as we had a very interesting interest among the community, and they indeed were very interested in PrEP and ended up enrolling in our study, although the numbers are small. So these results will help our government to make decisions on PrEP incorporation into the public health sector, and we keep following the participants, and we will soon report on the results of the study completed. Thank you.
Thank you, Beatrice, and I think the whole community has been interested to hear what the real-world uptake and interest is likely to be. So 51% is an impressive number. Moving back to the U.S., we'd like to welcome Sybil Hosek. She is a clinical psychologist in the Division of Child and Adolescent Psychiatry at Stroger Hospital of Cook County in Illinois. And she's going to speak to the data from the ATN, the Adolescent Trial Network 100 study, which is looking at PrEP uptake and adherence among young MSM in 12 U.S. cities. And young MSM, of course, are a population that we're all very concerned about. Sybil.
Thank you, Chris. Thank you for allowing me to present the data from ATN 110. ATN 110 was an open-label PrEP safety and demonstration study that enrolled young men who have sex with men across 12 cities in the United States. As Chris mentioned, it was supported by the Adolescent Trials Network, which is NICHD primarily sponsored. The study combined PrEP with evidence-based behavioral risk reduction interventions that were given to the participants at enrollment, as well as ongoing adherence counseling and sexual health promotion counseling. Eligible participants were 18 to 22-year-old HIV-negative men who have sex with men who reported HIV transmission risk behavior in the 6 months prior to enrollment in the study. Participants were seen at baseline, and then they were seen monthly for the first quarter, so monthly up through week 12, and then we went to quarterly visits through week 48. And much like the demo project, we used dried blood spots to quantify tenofovir diphosphate levels as our primary objective measure of adherence. We enrolled 200 youth with an average age of 20 years old. It was a very diverse sample, 53% self-identified as Black or African American, 21% white, and 17% Latino. We had 11 young men who were identified with undiagnosed HIV infection at screening, and we had 2 additional acute HIV infections at baseline. Those where there was a rapid test that was negative but viral load positive. We had high rates of any STI at baseline, 22% of the young men, and that remained relatively constant across the course of the study. There were only 3 adverse events that were deemed to be related to PrEP, 1 episode of nausea, 1 weight loss, and 1 headache. The vast majority of participants had detectable levels of tenofovir in their blood throughout the course of the study, and participants who reported condomless sex had higher levels of tenofovir, indicating likely better co-adherence. Regarding reaching that protective level, or that highly protective level of tenofovir of 4+ pills per week, 56% of our participants had tenofovir levels consistent with that dosing at week 4, but by week 48, 34% of participants had tenofovir levels consistent with 4 or more pills. There's a noticeable drop-off occurring at week 24 when we went from monthly visits to quarterly visits. In addition, there are noticeable differences in protective levels of tenofovir by race and ethnicity. Our white and Latino participants were consistently above the 4+ pills per week for the entire study, whereas our black African-American youth were consistently below 4+ pills per week for the entire study. We had 4 HIV seroconversions on study for an incidence rate of 3.29 per 100 person years. None of those that seroconverted had detectable drug at the time of seroconversion. So in conclusion, ATN-110 successfully identified young men who have sex with men who would really be appropriate for PrEP interventions based on their self-reported condomless sex as well as recent sexually transmitted infections. This PrEP program also successfully identified undiagnosed HIV-positive youth and linked them to immediate care in youth-focused and youth-friendly sites. PrEP was well tolerated with minimal adverse events. Adherence was good overall, but racial differences and disparities are apparent. And regardless of race or ethnicity, adherence decreased for all participants as study visits decreased in frequency.
Thanks, Sybil. Some really, really important findings there. I think I would just highlight that all 3 of these studies that you just heard about in different settings, different contexts, the consistent theme is that the people who are at the highest risk are the most likely to take PrEP, and that is very good news. Moving on now, we're going to hear from Faith Henderson, who's a health scientist at the CDC, Centers for Disease Control and Prevention in Atlanta. But prior to that was based with the CDC program in Botswana, Southern Africa, and she's going to present results from the CDC's tenofovir 2 PrEP study among young heterosexuals. So now moving to a heterosexual population of adults in Botswana. Faith, please.
Thank you, Chris. So in 2011, CDC released results of the TDF2 study showing that daily oral PrEP reduced the risk of HIV infection among high-risk heterosexual men and women in Botswana. Today, I'm sharing the results of a 12-month open-label extension to that study. These findings are important because this study more closely replicated a real-world setting than its preceding clinical trial. All the participants chose to enroll even though they received no financial compensation, and all were aware that they were taking an active drug that they knew was effective in preventing HIV. We enrolled 229 of the original 1,218 TDF2 participants. Each month, we provided participants with a 30-day supply of PrEP, conducted rapid finger prick HIV testing, and collected self-report data, including self-reported sexual risk behavior. And to examine tenofovir concentrations in the blood, we also collected dry blood spot specimens. And so for our findings, we observed no HIV infections during the study period. We also observed that sexual risk behavior declined over the course of the study, with the number of reported sex partners in the past 30 days decreasing by 12% among both men and women, and the number of sex acts without a condom decreasing by 39%. Our analysis of dried blood specimens collected from a sample of 120 participants found that, overall, these participants had detectable drug levels at 93% of their visits. Among those with drug level data, women had detectable drug at 87% of visits and men at 96%. Detectable drug levels are an indication of recent PrEP use. The high adherence to daily PrEP among women is particularly encouraging in light of some previous studies in which women experienced no protection against HIV because they were not taking PrEP as prescribed. Together with recent evidence from the ADAPT study among women in Cape Town, our study confirms that women who are at risk for HIV can adhere to daily PrEP. With women and girls accounting for more than half of all people living with HIV worldwide, and 10,000 new infections occurring among women each year in the U.S. alone, PrEP offers a much-needed female-centered method of protection for women at high risk. If you're interested in learning more about our study, please contact my media team in Atlanta at 1-404-639-8895 or email them at nchhstpmediateam@cdc.gov. Thank you.
Thank you, Faith. Nice to have those contacts. Our last speaker is my friend and colleague, Professor Professor Carlos Caceres from the Public Health, I'm going to get it right, Cayetano Heredia University in Lima, Peru. He's also the director of the Institute of Studies in Health, Sexuality, and Human Development there. Carlos guest edited a special issue of the Journal of the International AIDS Society, JIAS, that was released in conjunction with this conference. And that is a special supplement entitled PrEP Implementation Science. So it speaks very much to the implementation issues that we are discussing today. And he's going to give us some of the highlights from the research abstracts and expert commentary from the supplement. Carlos.
Thank you very much, Chris. And yes, this is how it looks, the printed version, although we haven't been able to print a large number. Unfortunately, the good thing is that this is JIAS, which is an open access journal, and it's going online right now, and it can be printed by everybody. This is actually not just our work at the university. I'm also here with a different hat, NIMUS, the Network for Multidisciplinary Studies on ARV-based Prevention of the Sexual Transmission of HIV. NIMUS is a network for researchers, policymakers, practitioners, and activists interested in the conduct, dissemination, and utilization of multidisciplinary studies in ARV-based strategies to prevent HIV transmission in a combination prevention framework. So yeah, we started activities last year, and one of the main activities, because producing special issues is difficult, we have to coordinate the agendas of very busy people, and fortunately we were able to come up not just with 8 but with 10 papers that really will help move forward in a phase where we realize that more and more people are starting to hear about PrEP and to imagine how it can be implemented in the context of combination prevention. The paper includes, the special issue includes first paper on the promises and challenges of pre-exposure prophylaxis as part of the emerging paradigm of combination prevention, which is an overview and with some of the history and the challenges. Then 2 papers which utilize modeling, one on Mozambique, seasonal use of PrEP among women who see their partners during 1 month of the year, and also in Uganda in the context of Connie Kellum's group, the combined use of PrEP and treatment for prevention in sexually discordant couples. Then there's a social science paper, Beyond Drugs and Bodies, Social Science Perspectives on PrEP, by Judy Auerbach and Trevor Hopp, which is an important paper getting into the social dimension and highlighting some of the issues. There are many other, because they tend to be context specific, but for part of the global north, it's an important point of entry into this discussion. Then we have 4 papers that are sort of geographically defined, and they are case studies. One actually for Southern Africa by Francois Venter and colleagues, and one for by Don Colby and colleagues for Thailand. One actually by Vandilea, Fabio, and Beatriz for Brazil, and one by Ken Meyer and colleagues for the US. There's one important paper that fortunately was added, was the last addition, and I'm really grateful it happened. It's Rethinking HIV Prevention to Prepare for Oral PrEP Implementation for Young African Women, by Connie Kellum and colleagues, and I think it's going to start the discussion for women as well, or to strengthen that discussion. And finally, we have one by Ken Hopkins and colleagues on translating PrEP effectiveness into public health impact, key considerations for decision makers on cost effectiveness, price, regulatory issues, distributive justice, and advocacy for access. No? In fact, Mitchell participating in this one, representing EVAC. the group of guest editors, I was honored to have Ken Meyer, who is a member of the Governing Council of the IAS, and also Rachel Bagley and Kevin O'Reilly from the World Health Organization. And we had fantastic collaboration with Marlene Bra from the Journal of the International Society and the team there. I think a very professional agenda to complete the many steps that this process requires. But I can really, to conclude, I can say that in our view, this is a collection of timely contributions from global leaders in HIV research and policy, which addresses geographic diversity, adopts a transdisciplinary stance, and covers a variety of complex issues raised by PrEP. As it will become accessible to all, we honestly hope that it will remain a valuable resource for policy makers, program managers, researchers, and activists around the world at a moment of a paradigm shift of the global response to HIV. Thank you very much.
Thank you, Carlos. And now I'd like to open it up for your questions and comments. I think we've had some really groundbreaking news from the panel today. Let's get started. And please do state your name, your media outlet, and if the question is directed to anyone on the panel we would like to speak to. Please.
Hi, I'm Mike Kavanaugh from HIVHero.org, and we're a website that helps newly diagnosed people living with HIV. I have a question about PrEP as far as long-term effects. Is there any studies done about what's going to happen if you take this drug on long-term, and is there any new information about that? And secondly, my problem with recommending PrEP, which I think is a great tool, and I laud you on all the research you've done, is that are we including any kind of research about other STDs that are being, because people are not using condoms, and especially in New York, I found that many people are using PrEP as an excuse to not use condoms anymore. Is there any correlation to any kind of studies that say that other STDs are going up?
So I think Alan Liu is going to take the question on longer-term effects, and then we heard actually data consistently on condoms and STIs from all the speakers. So the levels were low, condoms that they didn't go down, and the STIs were moderate to high, and they didn't go up. So I think everybody actually addressed that. But if anybody wants to reiterate it, no, okay.
Okay. So in terms of the long-term safety, the drugs that are currently being used for PrEP, tenofovir and emtricitabine, have been used extensively for HIV treatment, and we do have a large amount of safety data suggesting that these drugs are very safe and well tolerated. For HIV-negative individuals, we have so much shorter period of follow-up, but that is growing, and some of the PrEP trials went on for quite a few years. For example, the IDU trial went on for over 5 years, and so we're amassing more data as well. And in general, the drugs appear to be well tolerated. There is a startup syndrome that people can have some symptoms early on, but generally those improve over time. And in terms of kidney toxicity, which is something that is associated with tenofovir, it's generally been rare in PrEP studies and generally unconfirmed upon repeat testing. So we are continuing to collect additional safety information on our ongoing studies, but the data are encouraging.
Ed Southman with HD. Question for Dr. Liu and Faith Henderson. In Botswana, the rate of patients who were taking their drugs is very high, almost 100, close to 100%. Is that due to the fact that you have a much higher rate of HIV in the community, rather as opposed to your study?
So I think one thing to keep in mind about these participants were that they participated in a former clinical trial, the TDF2 trial. So they were very much aware of the drug being effective. And so they knew that they were taking the drug and not taking placebo. And we believe that that, as you know, lended to the higher rates of adherence that we were observing.
And I would say that the adherence in our study was actually quite high and higher than what we've seen in prior studies, open label extensions of PrEP. And part of that may be that this was a new cohort of people that were enrolled and most of them weren't previously in other PrEP trials. But I think PrEP acceptability and knowledge in the community is increasing. And also we saw that the number of folks coming into the study referred from their peers was increased over time, and that may also be a source of motivation to take the drug.
Do these studies indicate that now is the time where you can recommend this treatment to your patients? And do you recommend it to your patients?
I think taking PrEP is an individual decision. It's not for everyone, but certainly for people who are interested in the strategy, I think it's worth having a discussion with their provider, and it is something that we do recommend for our patients.
Dr. Beyrer, you want to weigh in on that?
I'm sorry, I just was getting a ping from the Washington Post, so I didn't actually catch the last part of the comment.
Is it time to start recommending this as routine in your PrEP?
Well, I think PrEP is always going to be for people who are at substantial risk and who are interested in taking it. But I think what we want to move toward, and I think where the WHO is going with guidance, is that there's going to be a recommendation that is broad for people who are at substantial risk of HIV acquisition, and I think that's the way to go. We now have the evidence, and it's compelling across different populations. So for men who have sex with men, it's perhaps the clearest in most studies. For transgender women, it's quite clear, although the numbers have been small. But there's also a trial in men and women injection drug users. And of course, there's also this very compelling data from discordant couples in a number of African settings. So that's a pretty broad range of people who all of us, I think, would agree are at substantial risk for HIV. Yeah, please.
Hello, my name is Pablo Linde, from Paris, Spain. I wanted to ask all of you who are working in the developing countries area, taking into account that in these countries most of the people who need RT don't get it, it's realistic to the implementation of PrEP. And other question is, in some areas of Africa, in some communities, the rate of VIH is 40% or around it. The population risk will be all the community for taking PrEP.
Maybe, Beatriz, maybe you would want to speak to the access issue with Brazil.
Yes, so going to the Brazilian context, we are very fortunate to have universal access to HIV treatment, HIV testing, condoms, and ART with monitoring. So we are very privileged. And then PrEP would be an addition to this package.
I must say that one of the announcements in this conference has been actually 15 million people on treatment, and definitely in one way or another the world has been able to achieve high coverage of treatment in many countries. Fortunately, in Latin America, most governments pay for HIV treatment for all. We have universal treatment access to treatment in Peru, and I think in most of the region that's the case. In some cases, that is covered by the Global Fund, but in most of South America, it's completely funded by the government, not as in the case in my country. So I think that's not a problem. Probably the issue of what version of the drug is going to be used, if it's Truvada or if it's a generic, it's going to make a difference. I mean, those things are probably going to will have to be considered. But definitely, we're in a different scenario, and there's more access. And the other thing is this is not something for just personal benefit. We have to look at PrEP as a strategy that has a population level rationale, where it's a public health consideration, and avoiding one infection in somebody who might have a potentially infecting contact with somebody else very soon in acute infection is something that might avoid several infections. So that is the kind of benefit we have to keep into consideration.
You have the next question.
I'm sorry.
Oh.
So I'm from Adam's Love, which is a leading web-based program in Thailand and Southeast Asia. We recruit MSM online and we've been very successful. And I'm working with Dr. Don Colby for enrolling MSM into PrEP services, PrEP 30 service. What I want to ask you guys is, what are the challenges that you're facing in enrolling MSM into PrEP? And how are you enrolling MSM into PrEP service? Because I recently launched a huge media campaign, and we got so many press releases, but it's still difficult to enroll MSM into PrEP service. So what strategies are you using to enroll MSM?
Well, I guess we're not doing it. I can provide a general comment. Definitely, there are places. It's interesting that in some cases you are concerned. Some people are concerned about everybody taking PrEP, but definitely in many other places, very few people. Too few people are actually taking it. Probably the ideal thing from the point of view of public health is that people who need it, those who are not, for whom condoms are not working, who want to prevent infection, but for whom those for whom condoms are not working, actually decide to take PrEP. It has to be voluntary, and the programs, if they are going to be funded by governments, they should also have a criterion of priority based on need. So if those things are considered, ideally, if there's education of the public and education of providers, we could have a match that would lead to the most efficient use of PrEP.
So we did like 300 behavioral surveys with MSM, and we wanted to ask them why you don't want to take PrEP. What they answered is, it's a very scientific term, and people are not really understanding what PrEP is. So I think we need to simplify that and come up with some simple strategies so MSM really understand what PrEP is.
Please, this gentleman with the blue shirt is patient.
Giulio Maria Corbetti from Lights, Italy. We are talking about daily PrEP in your implementation project, of course. But I wonder if there is any way, in your experience, to counsel people who show lower level of adherence about some kind of strategies in taking PrEP. Be sure to take your pills 24 hours before you have sex, or if you've been reported by the participants some strategy of take of PrEP who show effective.
So we've tried a lot of different strategies, particularly for the young people in our studies. And I think some of the more effective ones really are the routinization of PrEP very early on, where their patterns of PrEP adherence get cemented early, and if they don't get off to a good start at the beginning, they have a much harder time catching on later on. A lot of folks tend to believe that their schedule daily is a lot more consistent in the mornings, where things towards the afternoon and particularly in the late evenings fall apart or kind of go haywire, so they like to take the pill earlier in the morning. And then we're also looking at a lot of different strategies, and maybe Al can talk about one of his recent studies looking at using mobile technology to interact with young people, whether it's daily reminders or weekly reminders or check-ins or push notifications, just to kind of help get them on track and remind them about using PrEP. And mobile technology seems to be very acceptable, in fact the most acceptable form of communication that we find with our young men.
The thing I wanted to add is that as opposed to clinical trials where when people get in, because of the methodology, we need to keep people there and we hope they will be adherent. Based on that, we'll be able to demonstrate whatever we would or would not demonstrate. In real life, I mean, if a strategy doesn't work, I mean, if people are not showing adherence, then that's not, I mean, officially they will drop because that strategy is not working for them. They will keep using whatever they can use. So I guess PrEP used in real life allows for judgment of, I mean, or trial periods where we can establish if something is going to work. You know, it can be improved, or if it definitely doesn't work for somebody. You know? So I guess we can do that. And the studies, you know, like Proud and others have shown that people who get to take PrEP and take it with high levels of adherence are people who need it, who feel that they are at risk, who want to prevent HIV, and who are not doing it well with condoms. So definitely, because they are not using condoms very much, they don't drop condom use. They adhere well, and they feel much better psychologically because the level of anxiety goes down.
Yes, is next.
Yeah, just a couple of quick ones and a sort of remark. Sybil, I probably just missed it. How many young men were in your study?
200.
200. To Faith, so you only had 20% as many as you did in the original study. They were all people who were in the original study?
Yes, that's right.
Is that because this was a pre-planned number, or did you get a lot of people saying, no, I don't want to try it again?
Actually, everyone was eligible to return to join the open label. So out of the 1,218, there was a lag time that occurred between the end of TDO2 and the beginning of open label. And so we had difficulties contacting our former study participants, but we used a variety of different ways to reach out to them through the media, through newspaper ads and radio ads and phone calls and text messaging. So that kind of accounted for the 229 that ended up enrolling. But the one thing I didn't say was that of those who returned, 86% did join the study. So once we got them in, the interest was very high.
And just a general remark, partially prompted by Carlos's journal. I mean, it's great that there's papers from all around the world, but there isn't one from Europe. And I would like to make a bit of a plea for continued research in Europe, because we've just done, and I speak as chair of the Crown Study, and co-chair, two pretty important studies. And we're also, let's not forget, in Central and Eastern Europe, host to one of the most exponentially accelerating epidemics in MSM, and of course a continued epidemic in people who inject drugs. And so this is particularly a plea for the CDCs and the HPTNs of this world to think about studies in Central and Eastern Europe, perhaps in partnership with the European community.
Thanks for that. It's an important point. You know, I think one challenge in that region I'll just share with you is that for the most part the way we all perceive and conceptualize PrEP is that it's part of a comprehensive prevention package. And so if the other pieces of the prevention package are missing or illegal, it gets very difficult to try and implement PrEP. So for example, what's the design of a PrEP intervention for injection drug users in Russia where you can't do methadone, buprenorphine, or needle and syringe exchange? And so the community actually is very challenged to think around those issues, and so are we as investigators, and the ethics are complex. So I absolutely hear you, and I absolutely agree. I think we would all agree that the ideal is that the basics of prevention services are available to people, and PrEP gets added to a combination package. That's the ideal. We know we don't live in an ideal world.